Welcome to MEDTALKS with Dr. Moin. Today we have Dr. Chakravarthi, who is a famous nephrologist. Sir, thank you so much for coming to our studio and spending your valuable time for us. We are going to talk to Dr. Chakravarthi about kidney problems. Though we all know that nephrology is a subject branch which deals with all kidney problems. So we will ask few questions and sir is going to answer to our questions and clear many doubts which you all have. What is nephrology?
So, nephrology is study of nephron. Many of you may not be aware, kidney has a fundamental part of it, which is the functional unit. We call it as a nephron. It comprises of a very small filter wherein the blood gets filtered and the urine is formed, and the urine goes through a tube called nephron. So, nephron is a functional part of kidney, and nephrology is study of the kidneys.
This is nephrology. And there is another branch of medicine, we call it urology. And how different are these two branches of medicines, nephrology and urology?
So, if you look at the urinary system in the body, human body, you have a kidney, you have a tube which connects the kidney to the urinary bladder called the ureter, and from the bladder, another tube which brings the urine to the outside environment, which is called the urethra. The entire system is called as a renal system urinary system. The medical aspects of this, the diseases which are treated medically, the whole subject is called as nephrology. The surgical branch of this is called as urology. So usually the nephrologist and the urology work as a team, because the same patient who has a medical problem, when he needs a surgical solution, will be referred to the urologist.
What are the most common diseases people come across in nephrology?
Broadly, we say kidney diseases are of 10 different types. I do not think we'll have time to go through all of them. Most important, conceptually, for you and me, there is something called as an acute problem and something called as a chronic problem. When we say acute, we assume that the patient's kidney function is normal till yesterday. Something happened today, function has deteriorated. So it is a temporary problem. In other words, it's called as a acute kidney disease. If a person has slowly worsening kidney status over many years, we call it as a chronic problem. In a country like ours, we have a huge burden of kidney disease. The SEEK study, which was done some time ago across the country, puts the incidence and prevalence of kidney disease around 18% of the population. That means out of every 100, 18 people have kidney disease.
It's quite a large number, sir.
That's a big number, and it's a huge burden which our country cannot afford. So what Dr. Moin is doing today to increase the awareness of the community with these should go a long way in preventing both the acute problems and also the chronic kidney disease.
Thank you so much for your appreciation towards our program, sir. The agenda of our program is to educate everybody. Layman's world is bigger than the world we see across in the hospitals, in the medical fraternity, and many people like undergraduates, postgraduates, and the specialists, the different specialists who don't deal with nephrology should also have a basic knowledge. This is what we are trying to do, sir. There is a acute kidney disease, there is a chronic kidney disease. So some people, they have sudden renal shutdown. So it comes under acute kidney insult, right? So, sir, what do you have to say for these kind of people? How to protect their kidneys? Who doesn't have a kidney disease, first of all, and having a kidney insult?
So as I already told, we are assuming the patient did not have any kidney disease before, and suddenly something has happened. In our own experience, we find most often kidney disease is totally silent and asymptomatic. So I do not know that I am suffering from a kidney problem. That is the reason sometimes we think the acute problem has happened today, But in reality, it has been going on for some time. That brings us to the discussion of when should we look for a kidney disease.
Right, sir.
If somebody has a risk factor, they should have an annual checkup for kidney disease. When I say risk factors, commonly we talk of patients who have known diabetes, hypertension,
Right.
those who have stone disease
Right.
in the past, those who have had urinary tract infections,
Yeah.
and those who have to take medicines for any reason in the long term. And finally, those who are having a family history. Any one person in the family has kidney disease, and all the other list of 5 which I told you, annually we want them to have a small test called as a blood and a urine test to pick up any kidney disease that is there.
Okay.
So there's, even if it is silent, you are able to pick up a underlying disease.
Okay.
Coming to Dr. Moin asked, when do we actually have that acute insult? Most of the times acute insults are very simple. One, dehydration.
Right.
Somebody can have a simple diarrhea which is not improving in 1 or 2 days, can have a renal insult.
Right.
Somebody can take a medicine for some other reason, for example a painkiller, and have an insult in the kidney. Any infection anywhere in the body can be an insult on the kidney. Commonly, these are the reasons why somebody has an acute insult on the kidney.
Okay.
So if somebody has totally normal kidney yesterday, today we have an insult, we call it as an acute kidney injury or acute kidney disease. But even asymptomatically, if somebody has a chronic disease, has an acute insult today, we call it as acute on chronic disease.
Right.
So whenever somebody has an underlying chronic disease, a acute is easy to happen because the reserve kidney function is already compromised.
Right.
Therefore, the insult which is small can still be a significant one.
Okay.
Whereas somebody has a normal kidney function, he may need a bigger insult to cause a drop in the function. Whereas
Right.
somebody already has an existing chronic disease, small insults also can be significant.
Okay. Sir, it's an amazing thing, sir. You just said mentioned all these points. Diabetes is one set of disease where it can cause, acute to chronic. It can just, take you from what you call, it is one of the complications of the diabetes.
Yes.
You call it microvascular complications of diabetes is nephropathy, which nephrologists deal with, and they diagnose it at a point where your kidney parameters are worsening. And there are some parameters, sir, you check blood urea, creatinine, and what are those levels, sir? You watch the people to monitor.
So as we just discussed, we have a simple set of tests. One is called serum creatinine,
Right.
which can be used to estimate the kidney function.
Right.
As I already mentioned, kidney has microscopic small filters
Right.
called as glomeruli.
Right.
There are 1 million glomeruli in one kidney. All these simultaneously function to make urine. This, in other words, is called as a filtration rate per minute.
Right.
So when I talk about kidney function, I'm actually talking about ml of blood cleaned of the toxic substance which is supposed to come out of the blood.
Okay.
If you take urea as one of the toxins, so I see that normal human kidney function is 100 ml per minute.
Right.
I mean 100 ml of blood is cleared of urea per minute.
Okay.
It passes through these glomeruli, million glomeruli.
Okay.
As the disease progresses, this filtration rate, which is 100 ml per minute, comes down to 90, 80, 70, 60, like that.
Okay.
So when I say chronic kidney disease, something is happening in the kidney, dropping this filtration rate per minute from a 90 or 100 ml to a level where slowly it comes to 10 ml,
Okay.
wherein dialysis requirement happens.
Okay.
In other words, this filtration rate determines which stage of kidney disease you are in. Stage 1 is when my filtration is fine, it is above 90 ml, but there are some other abnormality in the kidney.
Right.
Similarly, each level of GFR is glomerular filtration rate.
Right.
So what I mentioned, serum creatinine, is a test which is done in the blood which will tell how much serum creatinine is there, which is used to calculate the glomerular filtration rate. It is known as EGFR, estimated glomerular filtration rate.
Right.
So this is a very, very simple test. You give a blood sample, which could be as less as 1 ml.
Okay.
They check for serum creatinine in that. They also take other parameters like your height and weight, serum albumin, and calculate the GFR. Annually, once you do this, along with your blood sugar checkup, blood pressure checkup, and another important test called as urinary protein loss.
Okay.
If somebody has protein in the urine, it suggests that they have a kidney problem.
Okay.
Normal people have no protein in the urine. These two tests, serum creatinine and urine protein, along with the blood pressure level, blood sugar level, should be done annually once for everybody who is at risk, which we discussed sometime ago.
It's an amazing thing, sir. There are certain parameters here Dr. Chakravarthi has said. Serum creatinine, blood urea, GFR, EGFR. All these things probably you should check with your nephrologist and you should follow their advice and check with these parameters to watch on your kidneys. Somebody has a kidney problem. Somebody is not on dialysis, but he has kidney problem. But a time comes when he needs to undergo dialysis. Somebody who is already having chronic renal failure. What are the parameters? Who is the ideal candidate for the dialysis?
So, when we have a patient identified as chronic kidney disease, typically we ask them to have checkup every 4 months.
Okay.
To look at the level of the glomerular filtration rate.
Right.
We have a lot of things in our hands today compared to even 5 or 10 years ago to delay the progression of the kidney disease. As I already mentioned, somebody comes to us with 90 ml GFR.
Right.
We take them over a period of many, many years without reaching dialysis.
Right.
We prevent the progression from occurring.
Okay.
Simple example, somebody has diabetes with a drop in GFR. You control the diabetes, the drop in GFR slows down. That means it becomes slower. So it takes more time for him to reach the dialysis stage.
Okay.
Similarly, every disease which affects the kidney can be manipulated in such a way that the drop in GFR slows down significantly and we can give dialysis free time many, many years for these patients. So every 4 months we ask them to do a list of tests so that we know the level of kidney function and we also know how to intervene and delay the progression further.
So as to protect the kidneys in people who already have kidney insult, acute, chronic. So optimal control of diabetes and hypertension is advised at any given point of time, right, sir? So, sir, what are the level of blood pressures would you advise in people who are having kidney problem and non-kidney problems?
If somebody has established kidney disease,
right,
there is a lot of studies in Indian patients and others to convey to us one of the key things that you and I can do to delay the progression of kidney disease is to control blood pressures.
Okay.
By and large, we are comfortable at a level of 120 by 80.
120.
In a small subset of population, we try to get lower than that.
Okay.
But 120 by 80 should be a level which we should be able to achieve.
Okay.
There are few people who have severe vascular disease. We don't want to achieve 120/80.
Right.
It can be 130 by 80 also.
Okay.
Anything above 130/80, there is data to support the kidney disease progression also is faster.
Okay. You have some choice of drugs for people who are having renal failure.
Yes. Though we have more than 10 to 15 types of BP medications today, once there is kidney disease, there are some of them which are very good to delay the progression of kidney disease.
Okay.
They not only reduce the blood pressure, they also do something to the kidney microscopic or molecular structure so that the progression slows down.
Okay.
So there are a group of drugs called ACE inhibitors and ARBs.
Okay.
I'll not go into those details.
Right.
And when we use them earlier on in the treatment protocol, the kidney disease slows down. Similarly, there are another set of drugs now For diabetes, which are known as SGLT2 inhibitors,
Right.
there is a strong data supporting when you use them early on in the treatment of diabetes, it delays the progression of CKD. Of late, in the last 3 years, these drugs, both the ACE inhibitors, ARBs, and SGLT2 inhibitors, are used in people who traditionally don't need them. What I mean is, in non-diabetic also, these
Right.
drugs are used. In non-hypertensive also, these drugs are used.
Right.
Because they have an effect on the kidney per se and delay the deterioration.
It's really very good information, sir. So, irrespective of whether you have kidney problems or you don't have, optimal control of diabetes and hypertension is essential. In people with kidney problems who have hypertension, as sir has mentioned, usage and choosing the right molecule like ACE inhibitors or ARBs is very essential, and that should be wisely chosen, and that should be done by the right specialist who is a nephrologist. Sir, now coming to diet, has diet got some impact on the kidneys? Is diet directly or indirectly proportional to the kidney damage?
So, over the last couple of decades, a lot of research has gone into how do we delay the deterioration in the kidney function.
Right.
We already discussed about optimal control of sugars, optimal control of blood pressures, avoiding certain drugs, using certain drugs. One common thing which all of us should know is kidney disease is not single entity. There are so many types.
Right.
I can recall 20 different types of kidney disease.
Right.
So when it comes to diet, to some extent it depends on what type of kidney disease we are talking with.
Okay.
But across the board, there are few things which can definitely improve the kidney health, and one of them is salt intake.
Okay.
Salt intake has directly proportional to the level of GFR falling year on year.
Okay.
And those populations which take less salt by habit have slower progression of kidney disease. Keeping this in mind, anybody who has got a established chronic kidney disease, we tell them to drop their salt intake to roughly 2 grams per day.
Okay.
There are a very small set of kidney disease patients who don't have any swelling. They have lot of urine output. We call them as interstitial disease.
Okay.
In that group, we don't restrict salt, but in all other groups of kidney disease patients, we restrict salt so that there is a direct correlation between salt intake and the progression of kidney disease.
Okay.
The other set of diet commonly people ask about is water intake.
Okay.
As I just mentioned, in vast majority of people, when the filtration drops, you don't excrete all the salt and water you take. So salt and water restrictions goes hand in hand.
Okay.
But when I say restriction, it does not mean that you don't take any liquid at all. We ask for at least 1.5 liters of liquid per day as a minimum in vast majority of people.
Okay.
There are certain people who have stone disease, urinary tract infections, all the interstitial disease which talked of. In them, we ask them to go up to 3 liters of liquid intake per day.
Okay.
And this 3 liters is not to be taken 1 liter in the morning, 1 liter in the afternoon, 1 liter in the night.
Okay.
We want them to take it over a period of 24 hours.
Right.
Typically, we ask for 150 to 200 ml of liquid intake every 2 hours during the waking period.
Okay.
300 ml at bedtime, which will wake them up in the middle of the night, 300 ml in the middle of the night. Bottom line, you don't come down below 1.5 liters of liquid intake. You have stone disease or recurrent infections, you want to go up to 3 liters.
Okay.
And this is to be taken over the period of 24 hours.
Okay.
Salt and liquid we have addressed. Other common thing that people ask about is protein intake.
Protein intake, right.
And this is something that has to be clearly understood. Protein is of different types.
Right.
Protein does not mean single type of protein. Broadly, we classify it into non-vegetarian protein and vegetarian protein.
Right.
The non-vegetarian protein is documented and proved to have an effect on the drop in kidney function.
Okay.
Therefore, there is a need to restrict non-vegetarian protein, but there is no need to restrict vegetarian protein.
Okay.
Even somebody has advanced kidney disease, we never ask them to stop taking vegetarian protein. I see patients day in and day out, they have stopped everything including dals and all types of protein. They become more emaciated, they get more infections because there is no protein in the body.
Okay.
So if somebody has kidney disease, we talk to them about salt, we talk to them about liquid intake, we talk to them about restricting non-vegetarian protein and not vegetarian.
Not vegetarian. It's really very informative, sir. Many of the people, they don't even know that protein exists in vegetarian form also. For our viewers, for your understanding, like sir has raised a very good point, and he has said that if you are working out, you still want to maintain a good physique and all, and if you are afraid that you don't want to have some kidney problems and all, there is protein available vegetarian form as well. Sir, now talking about dialysis. Now, when we are talking about dialysis, there are different types of dialysis we have come across. People say peritoneal dialysis, hemodialysis and all. So could you just enlighten us a few points on differentiating these two dialysis, or is there anything else apart from that?
So when we discuss about kidney disease progressing year on year, we started at 90 ml function, then came down to 10 ml.
10 ml.
The minute you are close to 10 ml, your serum creatinine is above 5 or 6 milligrams.
Right.
The nephrologist invariably tells you to prepare for dialysis.
Okay.
So one of the things that we do is give information about the types of dialysis.
Right.
There is a type known as hemodialysis, which means that it is a blood dialysis.
Okay.
You have to go to hospital, get yourself onto a machine, and the machine does the cleaning of your blood or purifying your blood.
Okay.
There is another modality known as peritoneal dialysis, which can be done at home. There is no blood coming out of the body for this.
Okay.
So in both the instances, enough knowledge about the entire process is important, and there are certain preparatory things that we do, like creating a fistula in the hand, wherein the blood can come out, go into the machine and come back into the body.
Right.
Similarly, for peritoneal dialysis, we need to keep a small catheter in the abdomen, wherein fluid can go into the abdomen, stay there for some time, draw out all the toxins and come out. So broadly, these are the two types of dialysis. One is hemodialysis, other one is peritoneal dialysis. There are sub-types or modalities of dialysis among hemo, like hemodiafiltration, among peritoneal, called APD and CAPD and all.
Okay.
We will not go into those details, but somebody can have the option of doing their routine job, whether he is an engineer or a doctor or a businessman, and they can still continue regular dialysis, which is suitable for them, that the nephrologist should be able to help you with.
So, rightly said, sir, there are different types of dialysis. As you said, for working people, which suits better, sir, like the hemodialysis or the peritoneal dialysis?
Once a patient reaches dialysis stage, we give option of hemo-peritoneal, both to them, and the third option of a transplant also. We will talk about transplant subsequently. Peritoneal dialysis is something that can be done when the patient is resting in the night. The machine can do it throughout the night and is free for the whole day.
Okay.
Keeping this in mind, for anybody who is having an active life, you can choose peritoneal dialysis or hemodialysis when you are okay to spend 4 hours 3 times a week in the hospital. Peritoneal dialysis is something that is very safe, easy, can be done even by children. So most of the children go on peritoneal dialysis. Most of elderly people go on peritoneal. Active young people, we offer peritoneal unless they are against it and they want to go for hemodialysis. Those who want to go for transplant early, we may not take them into peritoneal because we just put them on hemodialysis for a month or 2 and take them for a transplant.
What is the time like one should get ready saying that now I should go for a renal transplantation? Is there a criteria where you say like fine, now this is the time you should go on to a transplantation?
Every patient who reaches dialysis stage is a candidate for transplantation. There is a small subset of patients like young children who needed dialysis, we don't wait till they reach dialysis stage. We do transplant even before they reach dialysis stage.
Okay.
We call this as a preemptive transplantation.
Okay.
And there is data to support the outcomes are much better because children stunt their growth when they have kidney disease.
Okay.
So by giving them a normal functioning kidney, we ensure that they have good growth also.
Okay.
So preemptive transplant is one type wherein we offer transplant even before the patient reaches the dialysis. For vast majority, as soon as they reach dialysis stage, we start the dialysis and then offer them transplant, which can happen within 1 month of being on dialysis.
Okay.
Once they accept transplant, we start the dialysis, work up the person taking the kidney and giving the kidney.
Right.
We call the person taking the kidney as a recipient and the person giving the kidney as a donor. And both testing can happen within 2 weeks.
Okay.
So if somebody starts their dialysis on 1st of a month,
Right.
by 1st of the next month, we should be in a position to transplant the person.
I heard about kidney biopsy. Some people go for kidney biopsy for various reasons. What is the reason where you do a kidney biopsy and check for something? And is kidney biopsy a painful maneuver?
We discussed about some tests in the blood to look at level of kidney function. When we know there is a problem with the kidney function, but
Right.
we do not know why it has happened.
Okay.
It could be acute kidney disease or chronic kidney disease.
Right.
Once I do not know the reason for it, we do a biopsy.
Okay.
To give it a simple example, somebody has a fever,
Right.
they go get a blood test done. The blood test tells you have typhoid or malaria.
Right.
Treatment is given for typhoid and malaria, not the fever.
Right.
Similarly, when you have a kidney disease, we know there is a kidney disease, but we don't know why it has happened. We do a biopsy. It's like a small needle, like your injection needle,
Okay.
which touches the kidney, and a microscopic bit is taken, seen under the microscope to get a diagnosis. Once we get a diagnosis, as we discussed, we have 20 types of kidney diseases.
Right.
When we know which one of it is, we are able to treat it, sometimes totally reverse it, sometimes totally arrest the progression so that it doesn't progress any further. So biopsy is a very simple test like an injection. There is no pain associated with it. It should be done whenever there is a need for it.
Okay. Thank you, sir. This was really very informative. Now, in a normal and a healthy human being, he is having a healthy kidney and has got normal parameters. So, for his kidney wellness and for him to be away from all these acute and chronic renal disease, sir, is there any parameter or is there any precaution he can just take before he gets into this kind of trouble?
As we discussed, most kidney diseases are asymptomatic for a long period of time. Then
Right.
the symptoms start,
Right.
but it is too late for us to do anything at that time.
Okay.
One is, if somebody has a drop in urine output,
Right.
we give a lot of importance to that.
Right.
Somebody has swelling in the body, that could be a symptom of kidney disease.
Okay.
Somebody has a lot of urine output, that is
Okay.
also a symptom where the kidney is not able to concentrate.
Okay.
Simply we put it as how many times is the person waking up in the night to pass urine.
Okay.
Till 40 or so, once in the night waking up is normal. But if somebody is 40 or 30, wakes up 3-4 times in the night, we call it as nocturia
Okay.
or polyuria. That is an indication indirectly your kidney, there is something wrong. So decrease in urine output, lot of increase in urine output, both can be symptoms of kidney disease. Swelling in the body is a symptom.
Right.
Another important thing which we find people miss a long time is when they pass urine, a lot of froth coming in the urine.
Okay.
They pass urine into the commode,
Right.
even without any soap there,
Okay.
it comes with a lot of bubbles. It indirectly tells us that the urine has protein leaking in it.
Okay.
So when there is protein in the urine, you get a lot of frothing. So that is an indication of a kidney disease. Similarly, uncontrolled blood pressure can be a symptom.
Okay.
Blood in the urine can be a symptom.
Okay.
So these are some of the symptoms, but vast majority will have no symptoms, and that is the reason we want them to have an annual checkup.
Okay. We were talking about froth while urinating. something triggered to my mind. That is, people with kidney stones, people having calculus. Some people say taking beer is good for the kidneys. How far is that? Is it true? Is it a myth or is something there?
It is a myth because alcohol has a role in stone formation. Those who have regular alcohol intake will have more predisposition for stone disease.
Okay.
So somebody who has a established kidney disease, we suggest that they should cut down the amount of alcohol.
Okay.
And there is a link between the alcohol consumption and the progression of kidney disease. Similarly, smoking and progression of kidney disease. Both should be, smoking we should make it zero, alcohol we can consume in moderation. If somebody is taking every week, we ask them to cut down to once in 2 weeks or once in a month.
Somebody who is taking every day, what do you tell them?
Once in 2 weeks.
It's a difficult thing for some people, but you can always try. If you want to protect your loved ones, then start protecting your kidneys, because there are the people who are going to suffer behind you. Sir, could you please tell us about renal transplantation? Who is the person who should go for a renal transplantation, and what are the challenges? Person who is giving a kidney is a donor, and the person who is taking a kidney is a recipient, right? And there are so many things probably people don't know when it comes to renal transplantation. Can you just brief us about that?
So every person who has a kidney disease and has reached a level requiring dialysis is a candidate for kidney transplantation.
Right, sir.
The person can be a child who is as small as 10 kg in weight.
Okay.
So the criteria to accept for transplantation in a child is child should have reached at least 10 kgs of weight.
Okay.
At the other extreme, we have done transplants up to 74 years of age.
Okay.
So there is no bar for somebody older.
Okay.
But generally after 75, we discourage going for transplant because the amount of infections that can be associated with this particular immunosuppressive drugs.
Right.
Once we accept the person for transplant, we keep them on dialysis, good dialysis, and we work up the donor.
Okay.
Donor can be anybody in the family.
Okay.
We call by definition a near relative who can donate.
Okay.
By law, a near relative is a sibling,
Okay.
brother or sister, parent,
Okay.
either mother or father, offspring of a patient,
Okay.
could be son or a daughter.
Okay.
Recently, the Indian government has included grandparents in near relative.
Okay.
So when I take kidneys from any one of these near relatives,
Okay.
I don't need to go to the government to get permission.
Okay.
The hospital can go ahead, work up the recipient, work up the donor, and go ahead with the transplant.
Can spouse also be a donor?
So by law, if any one of the near relative is not available, a spouse, either husband to wife or wife to husband, is also accepted as a near relative, though there is no genetic matching. The donor who is ready to give should be above 18 years of age.
Okay.
Nobody below 18 years of age is taken as a donor.
Okay.
And up to generally 65 years, they can donate.
Okay.
Somebody beyond 65, we do a series of tests and sometimes we accept them.
Okay.
Because if they have no known disease and when we check them up, they have no problem, we can still accept them as a donor. We call them as a elderly donor and then take certain precautions.
Is there any restriction? Somebody who has got diabetes, hypertension, or any morbidities, like which stops them from becoming a donor?
Diabetic, we do not accept as a donor for the simple reason, tomorrow if they develop kidney disease, because they will be left with single kidney, they may progress faster.
Okay.
Every other person who has no known kidney disease, we'll check them up for any evidence of silent kidney disease and then we accept them. Somebody has a malignancy, also we do not accept, and at the time of donation, no infection should be there. No other contraindication as such is there if they have two working kidneys and there is no kidney disease.
Okay. This is very interesting. You said about like pediatric population who wants to receive a kidney. Sir, any child who is above 10 kgs can undergo a renal transplantation. And does that adult kidney, which should be obviously bigger size from his comparative normal kidney, is acceptable? It does that same job?
Adult kidney will take little more blood into it as soon as anastomosis is done.
Okay.
So what we do is we fill up the child with lot of volume and then release the clamp so that sudden hypotension does not occur. But adult kidney can go into the child.
Okay. Otherwise, getting a kidney transplant is really very difficult, especially in our country, and there is no motivation. Though government is trying to educate people that you have to really be aggressive, saving lives and donating your eyes, kidneys and whatever organs you can. Sir, would you like to say something about motivating the public, the people, that they should really come forward donating their organs, especially kidneys, and what is the protocol for that?
Whenever there is a road traffic accident and somebody unfortunately becomes brain dead, or they have a stroke and become brain dead, all the organs may be functioning though the person is brain dead. So most of the organs today can be donated. So we say when a person becomes brain dead, eyes 2, that means each one can give life to one person. Kidneys, 2 patients can get life. Heart can be donated. Lungs can be donated. There are a series of things which can give. So one person's loss of life can give life to another 8 people or so.
Amazing, sir.
So it is unfortunate the potential to do transplants every day because of the amount of loss of lives in other forms. We don't do it because of lack of knowledge, as Dr. Moin has said. Second thing, there is no motivation. And some people suspect the success stories of these, which is not true. We have started doing, for example, kidney transplants in 1971. And today many of the units, including where I work, every week we are able to do at least 1 transplant. And our success rates are close to 96%. So I believe public in general should understand the burden of kidney disease, which we discussed, how to delay the progression, and once you reach the stage, to start dialysis and a transplant. And if somebody in our families is brain dead, unfortunately, for any reason, we should come forward and donate these organs. Do not carry your organs to heaven. Heaven knows them. We need it here.
Exactly, sir. Wisely said. And these are the 5 points which sir has just said are very essential for you to understand, act on it. Sir, now can you just quickly tell our people what is the protocol? For example, somebody wants to donate his organs, for example, kidneys or eyes or lungs or liver. So could you just tell them how should they do it and whom should they approach?
There is a understanding of a donor card. I can carry it. But by Indian law, no donor card or no permission from the person who is already brain dead works. Your kith and kin have to know your wish that you want to donate after you are no more. So apart from registering for donor cards, you have to tell your family, this is my wish, and that as soon as brain death declaration is done, every hospital has a direct connection to the Jeevan Dan program in our state, which is very well run by the government of Telangana. The Jeevan Dan team comes, counsels the family, and they subsequently facilitate everything for donation. And there are a waiting list in the state. There are close to 360 people now waiting for kidney recipients. So the minute there is a particular brain dead donor available, the hospital contacts the Jeevan Dan people if the family is willing. But most hospitals hesitate to tell the family, brain dead, you should give organs, because they feel it is misunderstood. So it should be from the family's side that it should be a request to the hospital, and the hospital will inform the Jeevan Dan.
Amazing thing, sir. Wonderful information. So people, whenever you are in problem, whenever you are going through some hardships, you know what you do. You just expect some superhero coming from the heaven or the sky like Spider-Man, Superman. But you can be that superhero. If somebody is receiving a kidney, unless there is a donor, he cannot be saved. So think wisely, think about it, think twice. You can be the superhero. So as Sir has wisely said, heavens don't need your organ. So please think about it and help all those who are in need of kidneys, eyes and other organs. So thank you so much, sir, for giving your valuable time and talking to our viewers and giving lot of information about nephrology.